to the Egyptian Society of Cardiology review course. Myself, I'm Dr. Ahmed Fareed. I'm a cardiology lecturer at South Carolina University. I'm a fellow of the European Society of Cardiovascular Imaging. As a continuation to the module of heart failure, our topic today will be the hypertrophic cardiomyopathy. We will start by defining what is hypertrophic cardiomyopathy, and the consensus is that it's an unexplained left ventricular hypertrophy in the absence of other cardiac or systemic disorders in sufficient amounts capable of producing left ventricular hypertrophy. Why it is so important? Because it's associated with sudden death among young athletes. It's #1 killer among the young athletes according to the many registries. The most big of them is the one came from the United States. And it's primarily a genetic disease. There are many genes responsible for the hypertrophic cardiomyopathy, as we can see here, but the most important are these 3 genes: the B-myosin heavy chain, the myosin binding protein C, and the cardiac troponin T, and they represent more than 70% of the gene mutations responsible for hypertrophic cardiomyopathy. And these mutations are inherited in an autosomal dominant pattern. And the evidence suggests that gene mutations may alter sarcomeric function and secondarily lead to hypertrophy and fibrosis. So, because it's primarily a genetic disease, is the genetic testing the test of choice for this? Actually, the yield of genetic testing for hypertrophic cardiomyopathy represents 30 to 60% maximum, and it's expensive and it's not available in every place. And it's useful only for family screening at this time, not for the detection of the disease itself from de novo. And if a mutation is identified in hypertrophic cardiomyopathy patient, the genetic testing is the preferred screening method for the first-degree relatives of the patient. And if no mutation is identified, then the imaging is the screening modality to go for the screening in the first-degree relatives. Regarding the pathology and the morphological features of the hypertrophic cardiomyopathy, as we can see here, the histologic hallmark of hypertrophic cardiomyopathy is myocardial disarray, with short runs of severely hypertrophied fibers are interrupted by connective tissue. As we can see here on the panel B is the normal myocardium. We can see it is arranged in a regular fashion, but in the slide A on the left side, you can see here this is the disarray with interruption by connective tissue. And we have different morphologies and different distribution of the hypertrophy in the myocardium. Like we can see here, there's a subaortic type, there's a mid-ventricular type, there's an apical type, and there's a diffuse type. And also, it's affecting, if it is septal, there's different morphology like the reversed curvature, the neutral with a straight septum, the sigmoid with the basal septum that show the hypertrophy, and the apical where this is above the papillary muscle thickening. So we can classify the hypertrophic cardiomyopathy into 2 main big categories, which affect the management and how you approach the patient. You can classify it into obstructive hypertrophic cardiomyopathy and non-obstructive hypertrophic cardiomyopathy. And for the obstruction occurs either in the subaortic level or the mid-ventricular level, and the non-obstructive, you have a normal systolic function and impaired or with impaired systolic function. There is another variant called the apical hypertrophic cardiomyopathy, where it's another relatively rare variant of non-obstructive hypertrophic cardiomyopathy characterized by thickening of the LV apical myocardium, and the apical hypertrophic cardiomyopathy defined as hypertrophy confined to segments distal to the papillary muscles. And it's very rarely the condition affected the right ventricle apex or both the left ventricle and right ventricular apex. So let's talk about the epidemiology. It's approximately affecting 1 in 500 persons, and fortunately this number is fixed across many ethnic backgrounds, so it's relatively fixed among different ethnic variations. Let's go in more details. The obstructive hypertrophic cardiomyopathy represents 25 to 30% in the resting conditions, and with exercise it can reach up to 70% of hypertrophic cardiomyopathy cases. The subaortic type represents about 25%, and the mid-ventricular obstruction represents less than 10%. The non-obstructive represents around 30% of hypertrophic cardiomyopathy patients, and the apical HOCM represent less than 3% in non-Asian population, and in Japan, what's called a Japanese type hypertrophic cardiomyopathy represent around 13% and 25% of hypertrophic cardiomyopathy patients. Regarding the natural history and the progress of the disease, the cardiac hypertrophy in patients with hypertrophic cardiomyopathy may develop at any age. So you may find it in infants, you may find it in children, you may find it in adults, in elderly, and the most severe cases present immediately after birth. The most common and typically the hypertrophy developed during adolescence. During the adolescence abrupt growth, the hypertrophy starts to increase, and early in adulthood and plateaus after a period of wall thickening. And the later the development of the hypertrophy, the better the prognosis. So what's the pathophysiology of hypertrophic cardiomyopathy? It's mainly 4 points that are responsible for the occurrence of symptoms and morbidity and mortality of hypertrophic cardiomyopathy. The main factor is the LVET obstruction and the occurrence of mitral regurgitation. Also, the occurrence of diastolic dysfunction due to thick and stiff myocardium. The arrhythmias that occur and atrial fibrillation represent about 25% of patients of hypertrophic cardiomyopathy, and also the lethal arrhythmias, the ventricular arrhythmias, which are responsible for the sudden cardiac deaths in these patients. And lastly, the autonomic dysfunction that accompany hypertrophic cardiomyopathy, and it's weakened detected by the abnormal blood pressure response to exercise in these patients. So you have an obstruction, systolic anterior motion, and mitral regurgitation. It causes ischemia due to significant hypertrophy, mitral regurgitation, which also, when the obstruction result in decrease in the cardiac output. The diastolic dysfunction and diastolic sequelae raised to raised left atrial pressure and decreased in the cardiac output, and the symptoms that occur with hypertrophic cardiomyopathy. Regarding the symptoms or the clinical presentation, it may be asymptomatic, especially in the non-obstructive group that represent about 30% of the cases. But in obstruction, usually is associated with symptoms like dyspnea on exertion, angina, palpitation, but there are some warning signs that carries high risk, like the development of syncope, sudden cardiac death, and the systemic embolism after development of atrial fibrillation. So this is warning signs when the patient presents with symptoms from the hypertrophic cardiomyopathy. Regarding the physical examination, the findings are always abnormal when there is obstruction. So you rarely find the patient with obstruction without any clinical findings. But in non-obstructive hypertrophic cardiomyopathy, the abnormalities may be less obvious. So we here summarize the physical findings you find in patients with hypertrophic cardiomyopathy. You have the carotid pulse is bifid and jerky, and the GVP had a prominent E wave. The apical impulse may have a double apex or double impulse, so this is a palpable S4, or you may have the triple ripple if you have an obstruction, but this is rare finding, but it's very pathognomonic if you find it during the examination. The heart sounds, S4 is usually present, and you have, in case of obstruction, you have a harsh systolic murmur or left sternal border and the apex that changes with specific maneuvers like the Valsalva, squatting to stand, and the exercise leading to increase of the murmur. A separate mitral regurg murmur may be also auscultated in case of significant mitral regurgitation. So now you have suspected the patient to have a hypertrophic cardiomyopathy from the history, from the clinical examination. How would you proceed? Then you do some investigations for this patient. Let's start with the most simple, the ECG. You may have Q waves, left ventricular hypertrophy, ST and T segment changes that could suggest important diagnostic clues of hypertrophic cardiomyopathy. And although the ECG is sensitive, it's non-specific, and interpretation of its findings should be considered together from data from the echo or the MRI. And you may find in the ECG rhythm abnormalities, as we had said that atrial fibrillation is present in 25% of patients with hypertrophic cardiomyopathy. And this is the ECG findings you can see here. You can see here there is a criteria for the left ventricular hypertrophy with a voltage criteria and deep arrowhead to-wave inversion. The strain pattern is more exaggerated and more clear in this patient. You may also, for the Holter-ECG, you may do Holter-ECG in patient who is complaining of palpitation, or in high-risk group patient, as we will discuss later, who is the high-risk group. And it may reveal a non-sustained ventricular tachycardia or other ventricular arrhythmias that may re-stratify the risk of these patients. Let's go to the echocardiography, which is the main diagnostic tool for interpretation and for the management of this patient. You may have these findings in the 2D echocardiography. You may have asymmetric septal hypertrophy. You may have diffuse, concentric, or localized to the apex or the anterior wall. You may have thickness of multiple ventricular wall that can be assessed by 2D dimension echocardiography, and you may notice systolic anterior motion of the mitral valve, which is called the SAM. We can see here that the septum is significantly hypertrophied, and on the right side, you can see here this is a diffuse type of the hypertrophic cardiomyopathy. Also, you can see here the different distribution of the hypertrophy of the myocardium and how you can assess this in the short axis, and you can measure it in a very precise way to know which part is hypertrophied more than the other part. Also, you may use the M mode or the color Doppler to confirm your findings. You find here there is a systolic anterior motion marked by the blue arrows here, and also there is a premature aortic valve closure. You may notice it, which is a hallmark in patient with obstructive hypertrophic cardiomyopathy. Also, you can see from the image below, there is a significant systolic anterior motion with significant mitral regurgitation and evidence of turbulence in the LVOT. So this is a hallmarks for diagnosing hypertrophic cardiomyopathy by the echocardiography. Then go to the Doppler, which classify if this is an obstructive or non-obstructive. So the typical appearance in the Doppler is a late peaking signal dagger-shaped with a peak systolic gradient either resting or with maneuvers. And you could here classify it's an obstructive or non-obstructive, which make big difference in the management of these patients. And you can distinguish mitral regurgitation and intracavitary obstruction. You can see here, this is a resting gradient. You see it's very high. And also you can see here, this is a gradient with the rest and with the Valsalva maneuver are provocable, which make the patient have low cardiac output and more prominent left ventricular obstruction gradients. The LVOT obstruction with a resting gradient is defined as resting gradient more than 30 millimeter mercury or provocable more than 50 millimeter mercury. And the mid-ventricular obstruction is defined as mid-ventricular gradient more than 30 millimeter mercury and occur in 8 to 10% of hypertrophic cardiomyopathy patient. And we define the end-stage hypertrophic cardiomyopathy as systolic dysfunction with left ventricular ejection fraction less than 50%. We can see here from the image, the above image is representing the LVOT obstruction. We see the Eliasing at the left ventricular outflow tract. And in the second image, the below image, you can see that the level of obstruction is in the mid-ventricle with very high gradient, as we can see with the Doppler interrogation on the right side. In symptomatic hypertrophic cardiomyopathy patients who don't have significant pressure gradients at rest, a dynamic obstruction must be investigated. So if you are scanning a patient with hypertrophic cardiomyopathy and didn't find gradient at rest, you should do a dynamic obstruction test either with a Valsalva, with the motion, or even you need to do an exercise echocardiography for this patient. So this is the approach if you have a patient. So if you have a patient with maximum provoked gradient more than 50% at resting, then you start the treatment as left ventricular outflow tract obstruction. If you have less than 50 millimeter mercury, if the patient is asymptomatic, you can repeat the echo after 1 year. If he is symptomatic, you can go with a exercise stress echocardiography to provoke the gradient, and then you decide how to approach this patient later on. So the role of echocardiography in hypertrophic cardiomyopathy is the degree and distribution of left ventricular hypertrophy, the left ventricular systolic function, the left ventricular size, the left ventricular outflow tract obstruction, either resting or with provocable gradients, the systolic anterior motion of the mitral valve and the mitral regurgitation rate, the diastolic function assessment, and the left atrial volume. You may need to have a transesophageal echocardiography according to the most recent European Society of Cardiology guidelines in the preoperative if you are planning to confirm the mechanism of LVOT gradient, if it's not very clear with the transthoracic echocardiography, or during the procedure of alcohol septal ablation. In patients with apical hypertrophic cardiomyopathy may require contrast administration, and contrast can be used to evaluate for an apical pouch or aneurysm which may contain a thrombus. And we can see here, this is the contrast echocardiography, and it's clearly representing the apical type of hypertrophic cardiomyopathy. The main differentiation between the hypertrophic cardiomyopathy is either it's a hypertrophic cardiomyopathy or an athlete heart, and this table represents how you could differentiate this from the echocardiography. Regarding the distribution, in the athlete heart is usually symmetric, while in the hypertrophic cardiomyopathy is asymmetric. Wall thickness is usually more than 16 in hypertrophic cardiomyopathy. LV dimensions is usually normal or reduced, and other to the athlete, which is increased. And you have the LV filling pattern is usually abnormal in hypertrophic cardiomyopathy, which is normal in the athlete's heart. The regression of hypertrophy with decreasing in hypertrophic cardiomyopathy, it doesn't affect it, and it's present with the athlete's heart. There is marked ECG abnormalities in hypertrophic cardiomyopathy, which is not present in athlete heart, and the familial evidence of hypertrophic cardiomyopathy is present in the hypertrophic cardiomyopathy and not present in the athlete's heart. Let's move on to the more advanced cardiac imaging, the CMR. It's very important for the assessment of left ventricular volume, mass and function, regional morphology, abnormal papillary muscle morphology, the mitral valve abnormality, and the most important is the late gadolinium enhancement with evidence of fibrosis in the myocardium. And here you can approach a patient with cardiac magnetic resonance. If you have a confirmed diagnosis, it's used as a marker for increased sudden cardiac death and helps in the management. If you have an uncertain diagnosis, it helps you to know if the LVH is not recognized in the echocardiogram or to differentiate from hypertensive heart disease or athlete's heart. And this is examples of the CMR of patients with hypertrophic cardiomyopathy with different variants. And here you can see the late gadolinium enhancement images with showing fibrosis, which carries risk for sudden cardiac death in these patients. So regarding the management, how could you manage a patient with hypertrophic cardiomyopathy? There is some general measures, including the family screening of the first degree relatives and avoid any competitive sports. You have treatment for the symptoms and the obstruction, like you have medical treatments, pacing, alcohol septal ablation, surgery, the myectomy, and the heart transplantation as an end if the patient reached a stage of in the stage of the hypertrophic cardiomyopathy. And you have prevention of sudden cardiac death using the ICD. Regarding the medical treatment, you have medical treatment that used to decrease the contractions and relatively well decrease the level of obstruction, like the beta blockers, the verapamil and diltiazem, and disopyramide. You should avoid vasodilators as it increase the resistance, and you should hydrate the patient well to increase the volume and avoid the dehydration, which worsening the case of hypertrophic cardiomyopathy. So if you have a patient with hypertrophic cardiomyopathy symptoms, you start with beta blockers or verapamil if it has side effects or contraindication to beta blockers. Then if the LVOT gradient persists and symptoms persist, you add disopyramide. If there's still refractory symptoms, then you go to either the pacemaker therapy or the septal myectomy or ablation. The surgical myectomy, it's for severe symptoms despite optimal medical treatment. It entails removing of the part of the myocardial muscle that causing the obstruction, mostly in the left ventricular outflow tract, and it has a very high success rate without any noticeable recurrence of this hypertrophied myocardium. And also the alcohol septal ablation, it's a catheter-based procedure where ethanol is injected in the septal perforated artery that supplies the hypertrophied muscle, and this portion of the septum becomes akinetic and eventually leading to scarring, thinning in this area, but it carries the risk of development of complete heart block. So you have to assess the risk of the patient, the risk of complete heart block, the operator experience, and the patient shared decision making, and you either go with ablation or myectomy. Myectomy is always preferred in younger, healthy patients with longer life expectancy, active and higher gradients, and greater thickness, and coexistent structural disease, as it may be corrected during the surgery with the myectomy surgery. The dual chamber pacing, it's entailing optimizing the AV synchrony and altering the ventricular activation sequence with potentially long-term remodeling and widening of the LVOT. Randomized controlled trials didn't demonstrate significant and objective improvement, unfortunately, and it's now appear to only benefit about 30% of patients treated with pacemaker to relieve obstruction have lasting benefits. For the non-obstructive hypertrophic cardiomyopathy, if these patients became symptomatic, the symptoms are usually related to heart failure due to inherent diastolic dysfunction or atrial arrhythmia, or both, not due to obstruction. The treatment options for these patients are limited, and diuretics are often useful in the early stages in the management. Now, there is a very important part when you see a patient with hypertrophic cardiomyopathy is the risk markers for sudden cardiac death. Detecting hypertrophic cardiomyopathy patient at high risk for developing sudden cardiac death is important in informing appropriate clinical management, detection involving identifying risk markers, in determining the hypertrophic cardiomyopathy patient at risk for sudden cardiac death with calculation and categorization of risk. There is some established risk factors for sudden cardiac death, like the family history of sudden cardiac death in the first degree relatives, the occurrence of syncope, the non-sustained ventricular tachycardias in the ECG or Holter-ECG, the significant left ventricular hypertrophy more than 30 millimeter, and the abnormal blood pressure response under provocative condition like exercise. There is other potential risk factors that should be considered, like the LV apical aneurysm, the LV outflow tract obstruction, and the late gadolinium enhancement on cardiac MRI. And for the prevention of sudden cardiac death, the ICD implantation is recommended in patients who have survived a cardiac arrest due to VT or ventricular fibrillation, and who have spontaneous and sustained VT causing syncope or hemodynamic compromise and have a life expectancy more than 1 year. This is class 1 to add an ICD in these patients. So finally, we can see here, we can use it as either a primary prevention before occurrence of any ventricular tachycardias or sudden cardiac death in this patient. You should recommend the assessment including the history, the 2D echocardiography, 48-hour ambulatory ECG. If the patient has high risk markers, then you put the hypertrophic cardiomyopathy risk sudden cardiac death score. If you have a low risk, ICD is generally not indicated. If you have intermediate, ICD may be indicated, and if you have a high risk, this ICD should be considered. If the patient had cardiac arrest due to VT or ventricular fibrillation, or had spontaneous VT in ECG, or syncope or hemodynamic compromise with life expectancy more than 1 year, then the patient should have an ICD. And thank you for your time.